this meeting. Endometriosis is a common cause of pain and infertility, and it affects a lot of women. The diagnosis is mainly done by transvaginal ultrasonography. The treatment can be performed by surgery or by hormonal therapy. And during this webinar, we will describe the surgical treatment of some aspect of endometriosis. In particular, we will start with my presentation, which is the role of surgery in the treatment of deep endometriosis in patients who have infertility, who suffer infertility. Let's start to open the presentation. This is, can you see the slide? This is the title of my presentation, Surgical Treatment of Deep Endometriosis in Infertile Patients. Surgery is widely used to treat endometriosis, and we can use surgery to improve pain and quality of life. We can use surgery in some infertile patients who have bowel nodules that cause occlusion or subocclusion, or in patients with ureteral stenosis caused by endometriosis and hydronephrosis. Obviously, we must treat by surgery patients with a suspicion of malignancy, and in some cases, we may consider to use surgery to treat deep endometriosis before performing IVF in order to decrease the risk of complication related to ovarian stimulation for IVF or during pregnancy. Just to give you an example, this was an infertile woman. The patient had approximately 5-year history of infertility, and she was diagnosed with a big rectovaginal nodule that infiltrated the ureter. One kidney was lost. You can see the nephrectomy now. And the patient had IVF following surgical treatment of endometriosis and the nephrectomy, which was required because obviously there was a delay in the diagnosis. And again, you can see another case here that was again an infertile woman which had this apparently endometriotic cyst. Actually, this was a borderline ovarian tumor that was treated before allowing the patient trying to conceive. However, independently from the condition that I previously described, there are some patients that do not have the need to undergo surgery, but they may consider to be treated by surgery in order to improve fertility or in order to improve the outcomes of IVF and ICSI. Less frequently, surgery may also be used in the infertile patient that previously failed IVF cycles. Obviously, if we want to offer surgery to an infertile patient with deep endometriosis, we must be aware that she has a good ovarian reserve. She has no evidence of tubal occlusion if we aim to restore spontaneous fertility. And we must also check the semen parameters of the partner in order to give a real chance to the couple to conceive spontaneously. Actually, the studies that assessed the rate of spontaneous conception after surgery for deep endometriosis are methodologically not very good. In fact, they are mainly uncontrolled. They are simply retrospective or prospective observational studies. In most of these studies, the fertility status of the patient is not appropriately defined, and therefore patients that did not try to conceive before surgery were included in the analysis, and therefore we don't understand, reading the manuscript, if the study population is made only by infertile women or also by women with unknown fertility status. Furthermore, in several studies, it is quite difficult to discriminate between spontaneous conception and the conception resulting from IVF-ICSI, and therefore it is difficult to understand the role of surgery in improving spontaneous fertility. Finally, when we perform surgery for endometriosis, it is common to treat all the visible endometriotic lesions. Therefore, we treat superficial endometriosis, ovarian endometrioma, and in this perspective, it becomes difficult to really understand which is the role of surgery in treating deep endometriosis, because at the time of surgery, we also treat ovarian cyst and superficial endometriosis. Finally, the result obtained by published study are results obtained in the hand of experienced surgeons, and this result may not be easily reproduced by other physicians in peripheral centers. In this study, Professor Vercellini and colleague try to investigate whether the chance of conception is increased in women with rectovaginal endometriosis that are treated by surgery and compared with patients who did not undergo surgery. This was a patient preference trial that included women under 40 years that did not have a previous pelvic surgery. 44 patients underwent surgical treatment of deep endometriosis, and 61 tried to conceive without undergoing surgery. Notably, there was no significant difference in the 2-year probability of conception, which was 44.9% in patients treated by surgery and 46.8% in those treated by expectant management. And also there was no significant difference in the time to conception. Based on these findings, the author stated that surgical excision of rectovaginal deep endometriosis does not improve the pregnancy rate and does not decrease the time to conception in women with endometriosis-related infertility. In this systematic review, Professor Vercellini and colleagues assessed the pregnancy rate in women who had rectovaginal endometriosis and either tried to spontaneously conceive or underwent surgery. The pregnancy rate after surgery in different studies ranged between 19 and 65%, with a mean of 39%. And in patients who tried to conceive without undergoing surgery, the mean pregnancy rate was 24%, with a percentage of conception varying in different studies between 10 and 41%. Several factors affected the postoperative probability of conception, in particular age over 35 years, surgery by laparotomy, diagnosis of uterine adenomyosis, and the presence of bowel endometriosis negatively affect the chance of conception. In contrast, surgery by laparoscopy and surgical treatment of bowel endometriosis by segmental resection were factors predicting a higher probability of conception. How we should ideally assess the impact of surgery on spontaneous fertility. Ideally, we should perform a randomized control trial, including an homogeneous population of patients with deep endometriosis, and the effectiveness of surgery as a fertility-enhanced procedure should be assessed compared with the natural probability of conception of this population. And therefore, we should have a randomization between surgery, experimental arm, and expectant management control arm, with a primary objective that should be the natural conception rate. With this design, ideally, we should be able to assess if surgery gives an incremental benefit over the background probability of conception of this study population. And this was essentially the aim of this randomized control trial. Here you can see the published method of this trial, and hopefully this type of trial may clarify whether surgery for endometriosis increases spontaneous conception. Another relevant issue is whether surgery can improve the outcomes of IVF and ICSI. Actually, the available study assessing the treatment of the impact of the treatment of deep endometriosis on the outcome of IVF are mainly cohort study, retrospective or prospective, with quite small sample size, and we do not have a randomized control trial on this topic. Why surgery should improve the outcomes of IVF? Because surgery decreases the concentration of inflammatory cytokines in the pelvic cavity. These cytokines may affect oocyte production, the ovulation, the fertilization, and also the implantation. Surgery can restore the pelvic anatomy, and in this perspective, it may facilitate oocyte retrieval. And finally, surgery allows to treat hematosalpinx that are caused by endometriosis. Obviously, the tubal fluid entering the endometrial cavity may negatively affect the implantation, and therefore surgery may improve the rate of implantation. Here you can see two studies that assess the impact of surgery on the outcome of IVF. On the top, we have a prospective study that compared the impact of surgery on the outcome of IVF in the 179 infertile women. Patients who had surgery required a higher dose of FSIG to achieve follicular development. The number of oocyte obtained after ovarian stimulation and oocyte pickup was lower in patients who underwent surgery than in those who underwent IVF without previous surgery. There was no significant difference between the two study groups in the rate of fertilization, number of top quality embryos, and number of embryo transferred. However, the implantation rate was significantly higher in patients who underwent surgery before IVF, 32% versus 19%, and this was in agreement with a higher pregnancy rate, 41% versus 24%. Another study assessed the impact of surgery for the treatment of colorectal endometriosis before IVF-ICSI. The patient included in the study had bowel endometriosis. The study included 60 patients. Patients were treated by conservative surgery in 18 cases and by segmental resection in 42 cases. And in this study, the overall pregnancy rate was 60%. The cumulative pregnancy rate was approximately 42% after one IVF ICSI cycle, 65% after 2 cycles, and 78% after 3 cycles. A decrease in the cumulative pregnancy rate was observed in patients that underwent segmental colorectal resection compared to patients who underwent rectal shaving and full-thickness disc excision. And there was a trend for a lower cumulative pregnancy rate in patients who received the first IVF ICSI cycle after more than 18 months from surgery. More recently, a systematic review assessed the impact of surgery for deep endometriosis before IVF, and this systematic review demonstrated a statistically significant benefit for the surgical treatment of deep endometriosis before IVF. In particularly, the pregnancy rate per patient and per cycle was higher in patients who underwent surgery before IVF than compared with patients who underwent IVF without being treated by laparoscopy. Similarly, there was an higher live birth rate in patients who underwent surgery before IVF, and the first-line surgery improved the pregnancy rate per patient, both in patients with and without bowel endometriosis. Sometimes surgery may be used also in patients who had a previous failure of IVF ICSI. We have only small studies. Here you can see the 2 studies that are published in the literature. However, in a selected population of patients with good ovarian reserve and ideally a reasonable semen analysis, laparoscopy may be considered when IVF ICSI have failed and the patient refused to undergo other fertility treatment. In conclusion, most women with deep endometriosis can be treated by both surgery and IVF. If the symptoms can be tolerated, probably IVF should be performed before. Primary IVF has the advantage of shortening the delay in conception, obviously avoids the risk of surgery and also the risk of impairing ovarian reserve by removing ovarian endometrioma. However, IVF may have higher cost compared to surgery, and unoperated patient may face peculiar complication of deep endometriosis during ovarian stimulation for IVF or pregnancies, such as bowel occlusion, rupture of endometrioma, hemoperitoneum during pregnancy. Patients who have a very severe pain may request to undergo surgery because they refuse to tolerate this pain, and also surgery must be considered when we have subocclusive intestinal symptoms, ureteral stenosis, and obviously ovarian cyst with doubt of malignancy. Surgery has the obvious advantage of improving pain, but it may decrease ovarian reserve. And furthermore, it has the risk of complication, and some of these complications, such as pelvic abscess, may theoretically decrease the fertility of the patient. If surgery is performed, obviously, it must be done by laparoscopy because this improves the chance of conception after surgical treatment. Therefore, the type of treatment should be ideally tailored depending on the intensity of pain, on the history of the patient, on the ovarian reserve, on the presence of endometrioma, on the available data on tubal patency, and on the semen analysis. We have a scarce literature on the impact of surgical treatment of deep endometriosis on IVF outcome. As I said, we have only uncontrolled study, and up to now we do not have a randomized controlled trial. Therefore, surgical treatment of deep endometriosis should not be performed with the aim of improving the outcome of IVF. It may be performed in patients who do not tolerate the pain after the discontinuation of the hormonal therapy or during ovarian stimulation. Thank you for your attention.
Thank you so much, Professor Ferrero.
Good. We can probably go ahead with the program.
If no questions, I think we can move forward to the next speaker. If there's some questions, we can have a short discussion.
There is any question?
Professor Ferrero, I cite a question from our chatting box. Please check the information.
Thank you for the nice presentation. How can we manage endometriomas in patients undergoing IVF? Well, it is quite complicated because it depends from the size of the endometrioma, and also depend from the general characteristic of the patient. Ideally, I do prefer to always assess ovarian reserve, and in general to do IVF before considering surgery for the endometriomas, because always I have the concern of decreasing the ovarian reserve by doing the laparoscopy. When the ovarian endometrioma is really big, I consider a short period of hormonal treatment before performing IVF. This hormonal treatment can be GnRH analog, also aromatase inhibitor are very effective in quickly decreasing the size of endometrioma, and they may be considered before the IVF. Good. I believe that we do not have other questions. So I think that we can go ahead with the next presentation. Hi, Emad. It's a pleasure to see you here. How are you?
Good. Thank you so much for the invitation. It's a pleasure to be with you.
Thank you for accepting. I'm very pleased to see you. Please go ahead with your presentation.
So, hello everyone. I am really honored to join you guys for this presentation in regards of robotic surgery for deep endometriosis. This was a great segue from Dr. Ferrero into the topic, where he covered, when to do surgery and what to expect from the surgery. And now, kind of, my portion is to, if you decide to do surgery, what can you do and whether robotic surgery as a benefit. This is my disclosures. Nothing is relevant to this talk. The objectives today is to discuss the advantage of robotic platform in deep endometriosis, how to plan to maximize the benefits and to try to decrease the complications. As everyone knows, there is signs during the surgery that will show, that will give you a hint that this patient has deep endometriosis. The fibrosis, the dense adhesion, the distortion of anatomy, and the reduced tissue elasticity. All those are signs of deep endometriosis. The robotic platform has some advantage to offer, including the three-dimensional vision, the filtration of tremors, the less fatigue, and of course, the articulated wristed instruments. But also there is other disadvantages, including loss of tactile feedback, which is really relevant in deep endometriosis cases due to the dense fibrosis that those cases have, and of course, the extensive use of energy. Regarding what we know is the robotic surgery offer a benefit. Currently, like AAGL, in their position statement, in benign gynecological surgery, robotic is fairly compared to laparoscopy. There is no much difference. Of course, as Dr. Ferrero mentioned, doing laparotomy in these cases is really a big problem to achieve the goals of the surgery and to promote fertility. So we're not comparing at all laparotomy. If whether robotics offer a better modality than laparoscopy, it is still to be determined. One meta-analysis that was performed comparing robotic surgery to laparoscopic surgery found that there's no much different in outcomes. Definitely, robotic surgery might take a little bit of more intraoperative time. Again, we have to be knowledgeable that most of the studies, including in the meta-analysis, were done really kind of early on. So is this still holds true if we repeat the same studies nowadays? Is question to be answered. Also have seen that there's no much difference in comparing the length of hospitalization between the two groups. Also, in regards of post-operative or intraoperative complications, they are very comparable. But a lot of surgeons will tell you that, okay, I find a little bit of benefit when I utilize the robotic platform when I do deep endometriosis cases. And I kind of want to summarize why most people will tell you that in surgical presentation. So I'm going to talk about the first goal is kind of the ability to do the dissections millimeter by millimeter. So in cases where the pelvis is really frozen, it can be hard to see the anatomical structure, to dissect it away, to identify the lesion, and to be able to optimize exposure. We feel that using robotic platform can assist in that. So this is a young patient. She was complaining of pain and infertility for a long time, like more than 5 years. She came and she chose to proceed with surgery first. So as you can see, it was like really hard to understand her anatomy and to understand the relationship between the organs. She demonstrated a frozen pelvis and all the structures was really kind of glued together. And, I kind of tried to perform like a similar surgical approach for every patient. So usually try to open the parorectal space and to be able to isolate the ureter and lateralize it. And in this case, I couldn't find the ureter easily. So it took me some time. And I think the robotic platform really helped in taking the time and be able to start and to dissect and to open the parorectal space, as you can see here. And of course, the magnification, the clarity, and the dissection millimeter by millimeter usually helps. So in this case, as you can see, the ureter was glued into the mesentery of the rectosigmoid colon. So this is why it was hard to find in the first place. And you can think about this case, takes substantially long time. And there is not yet much publications regarding the ergonomics of robotics versus laparoscopy and comparing surgeon fatigue, but there is some kind of preliminary ideas about, how the robotic platform can help ergonomically during long cases. So as you can see here, the dissection is made millimeter by millimeter and trying to repeat on the the same procedure on the other side. So the dissection is usually an inverted L and an inverted L that unite together, and then they form a U-shaped. So you kind of, trying to get the, the two L's to meet and to form the U-shaped dissection. And as you can see here, the torus uterinus is glued into the rectosigmoid column. So dissection of the parectal space and then dissection of the true posterior cul-de-sac has to be done to be able to understand the disease. As you can see so far, we cannot find the disease yet. So we are trying to still find it. And then you kind of finally got into the posterior cul-de-sac and finally get the rectum off the posterior vagina and the cervix. And after that procedure, you could be able to get the rectum away. Of course, you have a rectal manipulator, a vaginal manipulator to be able to move the structures. When you finish dissecting the rectum out, you start finally to see the disease and to try to excise the lesions. In this case, she actually had just rectal shaving, and actually she got pregnant with IVF after surgery. This is the rectal disease, and we are going to shave it here. So another benefit that I believe the robotic platform is useful for is how to work in multiple compartments. So the idea is to combine work in anterior and posterior compartments, or even other compartments too. So this is another case, also long-standing history of pain and infertility. And actually, she was referred because of dysuria and bleeding in her urine analysis. And then in this case, she had a long-standing history of infertility. She also needed IVF after the surgery. And she actually were going into the surgery working only on the anterior compartment. So she have deep infiltrating endometriosis of the urinary bladder. And as you can see here, you kind of start to put some stents in the ureter to be able to visualize everything. And then you open the bladder to be able to find the deep infiltrating endometriosis. One of the good things about robotics is that the visualization is really good. You can really understand the trigonal anatomy, the relation between the UOs as well as the deep endometriotic lesions. And then you can mark the excision and to try to keep certain distance between the UOs so that you do not compromise the integrity of the ureters. As you can see here, you do excision, you continue to remove the lesions, and then after excision, the plan is to go and repair the cystotomy. Again, sometimes it is very hard to delineate the lesion of deep endometriosis. So as you can see here, we thought first we got all the endometriosis lesions out, but when you look closer, you feel that is a little bit more lesion left behind here. So again, visualization is key here. Again, we have to acknowledge that the tactile feedback is lost. So you only depend on visualization cues. Sometimes you try to mimic kind of tissue response to pressure like that to be able to see what is the fibrotic tissue from normal tissue. After excision of all the lesion, you start to working on the repair. Of course, in these cases, it's recommended to do tension-free repair. So bladder mobilization and dissection of the retropubic space is sometimes needed to be able to get the bladder together off tension. And again, the ease of suturing with the robotic platform, I assume this is a very important benefit. And you can do your closure and under great visualization and great ergonomics. In bladder DIE, we close the bladder in 2 layers, and of course, after the first layer, we backfill the bladder to make sure that it's watertight, and then after that, we do our second layer. The good thing about robotic is after you finish all of this and you get the bladder done, you can work on a different compartment. So in this patient, she has both posterior and anterior compartment DIE, and then we kind of do the same exact technique, the inverted L-shaped dissection, opening the parorectal space, and then dissecting of the posterior cul-de-sac proper to reach the lesion. And actually, one of the important things is that we should ask the patient about symptoms. So this patient has cyclic dyschezia that she thought this is kind of normal. So she was dismissing the symptoms for a long time. As you can see here, this is the deep infiltrating endometriosis on the anterior rectal surface. Again, dissecting the nodule, bivalving the nodule, and then after that, you start the shaving of the nodule. Again, if the thickness does not require more than a third of the thickness, then we probably prefer do shaving because of the risk of complications. And then the other thing is that the robotic platform can allow you to push your boundary and to actually handle pathology that you are not used to. A great example of this is diaphragmatic endometriosis. Again, this is a patient that presented with cyclic shoulder pain, and then we use the robotic platform to excise the endometriosis of the diaphragm. This was a great utilization of the robot because of the tremors. As you can see here, this was the left side of the diaphragm, and then there is also the heart was moving all the time. And then when I tried to decrease the surgeon tremors, so we utilized the robotic platform. Also, the beauty about using bipolar modality here, we used a bipolar energy in both hands because we didn't want to do monopolar energy, and which will cause fasciculation of the diaphragm even further and makes the surgery more difficult. It's the same exact principle, millimeter by millimeter dissection, and then excise the lesion completely, and then after that, you go ahead and close the defect in a traditional fashion. So again, you can also give you a chance to work on concomitant pathology. A lot of these patients, they present with endometriosis as well as fibroids, for example. So this is the patient that was admitted because of bilateral hydrouterine hydronephrosis. Actually, she was admitted in the hospital. Nephrostomy tubes were performed, and then she has a history of endometriosis surgery before twice. That was aborted. Patient had an MRI showing this posterior cervical myoma. When you go in, we first thought, okay, she has hydrouterine hydronephrosis. We couldn't put stents in because of the angulation. The trigone was pushed upward. So in this case, we just passed a very small Polic catheter, and then we injected IRCCS. Another good thing that the robotic platform can offer is utilizing the Firefly technology. So you go into the case, and as you can see, you can tell this is a case that again, a frozen pelvis. You cannot even see the fibroid. You cannot find the organs yet. You can, same exact principle of isolating structures, millimeter by millimeter dissection, and then you kind of find the organs. The use of the Firefly technology here really helps, when you're thinking about, where is the ureter, if this is so easy to find using, the Firefly near infrared with ICG injections. Same exact principle and the utility of the dissection with the robotic platform. As you can see, this was a really tough cases with a lot of small bleeders, so it was not easy to get the case through. But as you finish the dissection, you get the bowel off the way. The ovaries were plastered into the pelvic side wall and the ureters. Again, as you can see here, you can do a lot of the surgery on the Firefly mode. And then finally, after that, you start to see the myoma, the posterior cervical myoma, really deep in the pelvis. Again, reaching that low, really, the robotic platform actually have an advantage. You do the myomectomy in a regular fashion, and then you close the uterine defect. So again, the beauty about the robotic platform in offering, working on different pathologies. Again, also, the last thing I want to mention is that the ability to innovate. So the robotic platform allows us to see this is the patient that we kind of, she had symptoms. We could not isolate where is the rectosigmoid lesion. The serosa was completely normal. We used ultrasound robotic platform to be able to see, as you can see here, this is the DIE lesion onto the sigmoid colon, and this is the layers of the bowel right here, and you can see how deep it was. So again, there is multiple options that the robotic platform can offer. So again, thank you so much. I hope I didn't take much of your time, and if we have time for questions now or at the end, I'm happy to answer any questions.
Thank you. Great presentation. Let's see if we have any question. No, I can't. Lee, do you see any question? Just congratulations for your presentation.
Thank you.
Good. Let's go ahead with the last presentation. Professor Keckstein, are you with us?
So, can you see me?
Perfectly.
Okay. Thank you very much, Simone, for inviting me. Dear Emad, I'm happy to be with you, and I will just share my screen. And I go into my presentation. Great meeting. So I will talk about the new classification called #Enzian classification. Can you see my presentation?
Yes, yes. Perfectly.
Perfectly. Okay. So what's about that? We have so many classification seen during the past decades, and there are some new, but the #Enzian classification is a very special classification. And I tell you, what is the problem? The problem is that we want to describe the disease, and this disease has so various types, locations, sites, that it's not so easy to describe it very simply. But the mostly used classification is the ASRM classification, and this classification is also that classification for all publications and scientific work and so on. And let's have a look at that. What is the ASRM classification? It describes only the peritoneum, uterosacral ligament, ovary, and adhesions. Then we count points, and we have finally stage 1, 2, 3, 4. But what is with the bowel endometriosis, bladder endometriosis, adenomyosis, ureter, and other localization? They are missing. They are not respected by this classification. So what should we do? We have now, since we are much better, and we have seen these beautiful videos of Simone, and also this robot surgery, which shows that we do much more than ovarian and superficial surgery. We go into the pelvic side wall and we resect all the lesions, and we should describe it that we can compare the data. We have to compare the outcome of surgery, but also fertility, as we have seen in the papers of Vercellini. But when you look into all these papers, they only talk about ASRM classification, but where's deep endometriosis? In the meantime, we have much better ultrasound. With the ultrasound and with the description of the IDEA criteria, we describe the disease in detail, and we can identify all lesions. So how should we describe this? And the same with the MRI. We have a very good tool to describe the lesions here, bowel endometriosis, adenomyosis, pelvic side wall involvement, and so on. How should we describe this? And now I can show you, this is a report of an MRI, which I got from a patient from United States. She's a Mexican patient. She had the MRI in Mexico City. I do not speak Spanish. And she sent it to me, and I should look at that. But look at this. They classified it with the classification of Enzian, and I will tell you, it was so easy. With this classification, I immediately understood where are the lesions, what is the size. So this is a common language. That's what we need now in the future. And what is now the idea of the hashtag Enzian classification? Very simple. We divide all the compartments in the pelvis and in the abdomen in different compartments, and we give each compartment a big letter. For example, it doesn't work. Peritoneum, P. O, ovary. T is tuber-ovarian condition, adhesions. A, septum rectovaginale for deep endometriosis and vagina. B, for the ligaments, uterosacral ligament, cardinal ligament. C, for the rectum. FA, for adenomyosis. FB, for bladder. FU, for the ureter. So each has a big letter. But also if there are lesions outside of the pelvis, sigmoid, FI, sigmoid, we add then the anatomical site, FI cecum, FI small bowel, all bowel endometriosis, or F diaphragm, or F sacral root. So we have now these letters. And this is the classification. Peritoneum P, O ovary, T tuber-ovarian condition, ABC is deep endometriosis in the pelvis, and FA, FB, FI, and FU, these are other localization. Very simple, these letters, and then according to the size, we give the A1, A2, A3. Or for example, for the ovary, O1, O2, or 3, if the lesion is smaller than 3 centimeters, if it's bigger than 7 centimeters, O3. And each site is described. So the left and the right side, the same for the B compartment, for the uterosacral, and for the tuber-ovarian condition. Very simple. And for peritoneum, for example, if the sum of the lesions are smaller than 3 centimeters in a circle, it's a P1. And if the lesion is bigger, it's a P3. Very simple. Now, the idea is that at the end, you have a code. which covers all peritoneal, all anatomical sites. So it's complete and comprehensive. And this is new. We can use this classification for ultrasound assessment. Then we add a U for M for MRI, and for surgical assessment, an S. Let's have a look here. Uterosacral ligament on the right side. It's 1 to 3 centimeters. It's a B1. And on the left side, it's a 0, B0. And the sigmoid, more than 1 centimeter, smaller than 3 centimeters, C2. And this is now the final code. Surgical B0 left, slash on the right side, 2, it's more between 1 and 3 centimeters, and this is the C2 lesion in the rectum. So you have now exactly the description of the disease. Here we have seen this endoscopic ultrasound during robotic surgery. We have here, this is a segment which we have removed. You hardly can identify this lesion during surgery. You don't know where are the lesions. But when you open the specimen, you can see the very severe infiltration of the rectal wall, more than 7 centimeters. And we knew it in advance because we did an ultrasound to identify this lesion with this with the ultrasound, and you see the same size, the same size, same shape. And finally, we have the classification. It's an Enzian ultrasound and surgery, C3. It's bigger than 3 centimeters. So this is the idea which stands behind this disease. And the classification, the B compartment for each side, cardinal ligament, uterosacral ligament, B1, 2, 3, left, right. So let's have a look. Here we can do an ultrasound. With the ultrasound on the right side, here this is the white area, hyperreflexive. There is no endometriosis. On the left side here, you see this nodule infiltrating the uterosacral ligament. So we have on both sides different lesions. So it's 2.5 centimeters. On the left side, it's a B2. On the right side, it's a 0. A very clear description of the disease. Another patient here, ultrasound as well. You see here, this is a lesion on the rectosigmoid, and this is a very big lesion in the uterosacral ligament. So you have here the rectum and the uterosacral ligament. This is the rectum, this is the uterosacral. Very easy, rectum is C, uterosacral is B. So you have the B0, on the left side nothing, on the right side 2, and C2. So this combination gives you the clear description of the disease. Or for example, also the uterus. For example, this is the MRI of an adenomyosis. This is the ultrasound adenomyosis, and this is the surgical picture of severe adenomyosis. What is adenomyosis? Hashtag Enzian FA. Now, a patient with deep lesion on the septum rectovaginale, and you can see here uterosacral is involved, the torus uterus is involved, and also the rectum. I go further, and you can see by dissecting here, you can see we open the pararectal space, and you see uterosacral on the right side, torus, and the rectum is involved. Then we go further on, we do dissection here. This is the dissection of the deep lesion. The vagina is now open. This is the A lesion. And you go further on, you have the vaginal infiltration. And then you resect the uterosacral. So And then you do the shaving on the rectum. And you see there's still some lesion inside of the rectum here. And we decided that we have not been complete, so we did the disc resection with this transanal stapler. And then finally, we resected it, and you can see here more than 3 centimeters. So this is the final view. And then you have the peritoneum. A is the torus, B is the uterosacral ligament, and this is the rectosigmoid. So now we compared in a very big study the IRCCS with the Enzian classification, and you can see in the patient with IRCCS, this is the lesion 1, 2, 3 of the different Enzian compartments, and you can see even with stage 1 IRCCS, you have C, and C means rectal involvement. And even with a lesion more than 3 centimeters was classified with IRCCS 1. So it has shown that the Enzian classification is much more complete and more precise. It has also in several studies shown that there is a correlation with ultrasound picture. This is the big prospective study on more than 700 patients, which we compared the ultrasound classification with the surgical classification. And that's why the ISGE, for example, recommends when you describe the disease by ultrasound, please use the IDEA methodology and the hashtag Enzian classification. Now, this is a patient. I do always sketches. This is the bladder endometriosis seen in the cystoscopy, adenomyosis. Patient has a rectal endometriosis, sigmoid endometriosis, ovarian endometriosis, and you see here, this is the specimen, both nodules on the bowel, ovarian endometriosis, endometriosis in the regio inguinalis, and adhesions. And this shows with this classification by ultrasound and surgery, you get the same code. And this means we are very precise. And this is also possible by MRI. You see here the MRI video of the same patient. You can see there's the O compartment visible here. Then you can see the rectal nodule here, adenomyosis, bladder endometriosis. This is the nodule on the rectum. And you can use the hashtag Enzian also in the MRI. This is the nodule on the uterus, FA and FB, bladder endometriosis. This is the nodule on the sigmoid. And finally, also you have identified the nodule in the regio inguinalis there. And this is now the proof that with these different technologies and imaging and surgery, you get very similar codes. It has also been shown that it correlates with the MRI, with the surgical complexity and complication rate, which is very important. There are several papers now on that. Very simple, one example, you can see here the Enzian classification for deep endometriosis on the rectum. This is C1, C2, C3, the different size of the lesion. And now look here, operative time C1 is much lower than, shorter than in C3. And very important, the complication rate, Clavien 3 and 4. And this is for the prognosis and for the consultation of the patient. And the same with the MRI. You see the length of surgery, A, B, and C compartment, according to the size of the lesion, operative is bigger. This was done with the MRI. And for this reason, now there is an international inter-society project which shows which classification should be used. And the Enzian classification seems to be the most comprehensive classification for all different imaging techniques. And now the last two slides, we did a very interesting investigation. We have 40 specialists who used the different classification systems. This was the old Enzian classification and the ASRM. And there were 3 virtual cases, and they should classify it. And with the normal paperwork, there were no specialists could do it correctly with the ASRM. Using a computer system, which is called a QUSUM, you get a much better accuracy. And with the Enzian, it's also much better to have an accuracy when you describe the disease. So in future, probably we will use the computers to classify, and we will be more accurate. And for that, you see here, this is the code. It looks very, very difficult, but it is not. It's a very, let's say, systematic description. S, surgical, P, peritoneum, O, ovary, T, tuber-variant adhesions, B, uterosacral ligament. And now look here. If you're not able, as you have seen in the surgery of the robotic, you couldn't see the C lesion. Then you make an X and diaphragm. And now with the hashtag Enzian, you can include also your information which you got by the imaging. And here the C lesion with the ultrasound is added to your code, and also FA, which is sometimes not visible during the surgical intervention. So very simple. And to make it simple, now there are 2 apps to use. This is the first app to use. This classification was done by Arnaud Vattier. You just push here the different buttons, and then you get the code. And this is now also a new approach to classify it completely. In summary, the hashtag Enzian is comprehensive. We identify and we can control the progression of the disease. We have a much better possibility to make the most appropriate therapy. Prediction, prognosis, and complexity of the intervention is possible. Counseling of the patient is better. And what is now much more, and maybe we discuss it also, Simone, when you only use the ASRM classification, your data are not correct. And for the future, probably we get more reliable and more comparable data for scientific assessment. Thank you very much for the attention.
Thank you for your great presentation. I fully agree that the RSIM classification is not so useful from a scientific point of view. Do we have any question on your presentation? Let's see. No, I don't see question on.
Professor Ferrero, please check the chatting box. Yes.
I don't see question for Professor Keckstein. There is probably one question for me. I've been asked if endometriosis should be removed before transferring embryos in cases of multiple IVF failure. Actually, we have no study to recommend this approach, so we have no data giving evidence that we should remove deep endometriosis. There is some basic research studies suggesting that the excision of endometriomas and deep endometriosis may affect implantation. However, up to now, we cannot recommend surgery for deep endometriosis or for endometrioma in order to improve implantation. Well, there is another observation from the US suggested that endometriosis may affect implantation. This is actually quite true, but this doesn't mean that removing endometriosis improves implantation, because it is likely that in the endometrium of patients with endometriosis, there is something different which in some way affect the implantation, and it's not so obvious that removing endometriosis surgery will automatically cause an improvement in the implantation rate. I don't see any other question. So Lilian, I would give you the space for a few minutes of talk. Thank you.
Thank you, Professor Ferrero. So let me share my screen. Okay, so I'm gonna make a really brief introduction of our journal. And the Minimally-invasive surgery is an international peer-reviewed and open access online academic journal. And we have been indexed in Scopus, Google Scholar, Dimensions, and other database and memberships of some important database. And we welcome submissions within topics related to endoscopy and other minimally invasive procedures. And all other articles are freely accessible online forever. And we can support rapid publication, and the copyright of articles belongs to the authors. And the authors could have the opportunity for the webinars and the special interviews, and they give free promotion service. And at the bottom, you can find some dynamic data of our journal, and all these data could also be found at the bottom of our website. And this is some of our editor board members. We have 112 editor board members, including 38 youth editor board members, and Professor Ferrero is also one of our editor board members. Most of the members come from the United States, the United Kingdom, Italy, Germany, Japan, and the other countries or regions. And we also organize a lot of webinars and interviews in different fields, like the HPV surgery and the bariatric surgery, the urology surgery, and in different fields of minimally invasive surgery. And of course, we have had some interviews with some famous experts. So we warmly welcome all your participations in these activities. And this is a special issue guest edited by Professor Ferrero in our journal. We warmly welcome all your submissions. And this year, we also start a new section, our Youth Forum 2023. And the first section in the field of urology surgery has been determined, and the section of gynecological minimally invasive surgery is under planning. So welcome all your recommendation, and welcome to recommend candidates to chair our webinars and to join our webinar as speakers or attendees. Okay, so that's a really, really brief introduction. And I'd like to thank you all for your coming here today. And we really have a great webinar and great presentations. And thank you all for the attendees and of course, all our online audience. Okay, so Professor Ferrero, would you like to give some concluding remarks?
Thank you for the opportunity. I'm very grateful to the speakers because they prepared an amazing presentation. I hope they have been interesting for the audience and for you. And I look forward to meet you in person, Emad and Jörg, and hope to see you in Italy soon. Thank you for inviting all of us.
Grazie.
Thank you
very much.
Thank you.
Thank you. Thank you. Have to meet you next time. Thank you.
Thank you.
Goodbye. Thanks.
Buona serata.
Have a nice
Ciao.
day.
Ciao.